Now we're going to start talking about agents used to treat common problems of the eye, ear, throat, and mouth. A great many products are available for the eye. These drugs are the ones that we're going to talk about are the ones that are most commonly seen, and is really only a small representation of the many medications that are out there. The most two common eye diseases seen in primary care that are treated medically are infectious conjunctivitis and seasonal allergic conjunctivitis. Most eye conditions require referral to an ophthalmologist. Conjunctivitis can be both bacterial, viral, or allergic, and usually the ophthalmic antibiotics are just used for the bacterial conjunctivitis. Some are used to prevent secondary bacterial infections in viral conjunctivitis, but this is patient-specific. So again, conjunctivitis is the most common eye disease seen in primary care. It can be caused by bacteria, a virus, or allergy. Bacterial conjunctivitis is most often caused by Streptococcus pneumonia, Haemophilus influenza, Streptococcus aureus, a Pseudomonas species, and Moraxella species as well. Gram-negative infections are less common than the gram-positive infections. Haemophilus is the most common in children. Chlamydial infection is also an important cause of blindness, and bacterial conjunctivitis is often accompanied by large amount of purulent discharge. Some minor pain may occur with conjunctivitis, but no changes in visions have been reported in the conjunctivitis caused by bacterial, viral, or allergic reactions. Bacterial conjunctivitis is spread through contact, so good hand washing is very important to stress for parents, children, as well as any adults who do contract conjunctivitis. Viral conjunctivitis is far the most common cause of conjunctivitis. It's usually caused by adenovirus type 3, which is commonly called pink eye in children. This is extremely contagious as well. It's spread by touching infected secretions. The duration is from several days to 3 weeks or longer, and the eye can be very painful, and pharyngitis, fever, malaise, and pre-auricular adenopathy may be associated. The conjunctiva is red with large amounts of clear discharge. Herpes zoster conjunctivitis usually only affects one eye. However, it can spread to the other eye. It's usually when you see the zoster infection, you usually see following only one side. It does not cross the midline. The herpes zoster is usually accompanied by a vesicular rash distributed along the ophthalmic division of the trigeminal cranial nerve. Herpes zoster does not spread. However, you can get a secondary infection. Conjunctivitis is when you'll see both eyes, and this makes it a little more difficult to diagnose the herpes. Allergic conjunctivitis is common in patients with allergies. It's often seasonal but can occur year-round with allergies, especially to dust or mold. It presents with an itching and tearing and characterized by cobblestone papilla in the upper tarsal conjunctiva. Glaucoma is another condition that's managed by the ophthalmologist. It's common for a patient to be on 2 or more medications for glaucoma, and you should become familiar with these. The primary care provider must always be aware of possible systemic side effects of eye drops as well as potential drug interactions. There are many guidelines out there. The American Academy of Ophthalmology has preferred practice patterns for many ophthalmologic problems, and guidelines for conjunctivitis are reflected on their website. And you can access this at 1.aao.org. For evidence-based recommendations, randomized controlled trials have demonstrated no difference between the effectiveness of many antibiotics for bacterial conjunctivitis. So for conditions that require anesthesia, we look at the topical anesthetics that are used only when eye pain makes it impossible to examine the eye. Topical anesthetics retard corneal healing, and they allow for corneal abrasions to progress to a corneal ulcer. So you really want to limit the amount of use for these anesthetic agents. The anesthetics generally are used only by ophthalmologists. In the emergency department, they're sometimes used to remove foreign bodies or to do exams. However, they're mostly used by the ophthalmologist. If a patient is using them, the patient must use great care to avoid injuring the eye. Other eye problems, sympathetic ometics and vasoconstrictors are over-the-counter agents that are commonly used for relief of red eyes or irritated eyes. Generally, they're safe and effective. However, chronic use is discouraged because of rebound inflammation. Ocular lubricants, such as artificial tears, are also over-the-counter agents. These are very safe and effective in relieving irritated eyes. They're used in elderly patients especially, and in those who are on medications that cause dryness of the eyes. Fluorescein is used in primary care setting or the emergency department when the eye is examined for any abrasions of foreign bodies. When the strips are used, they should be moistened with sterile water. You're to place the moistened strip at the fornix in the lower cul-de-sac close to the punctum of the eye. The patient should blink several times and then allow a few seconds for the staining. An injury such as a corneal abrasion will show up as an intense green fluorescent color. Once the examination is complete, the patient should have the eye rinsed out with sterile irrigating solution. So cardinal points of treatment, you need to diagnose the cause of the conjunctivitis, whether it's bacterial, viral, or allergic. And ophthalmic antibiotics are only effective for bacterial conjunctivitis and are commonly used to prevent secondary bacterial infections in viral conjunctivitis. Effective treatment depends on an accurate diagnosis. Providers need to collect pertinent information and diagnose the problem. However, many problems require a referral to specialized care, such as ophthalmologist. You need to, if you're unsure whether it's bacterial or viral, you need to refer the patient. Ophthalmic solutions are absorbed systemically, and these can pose secondary problems. In general, any adverse reaction to the medication may cause when taken orally and can occur when the medication is given as an eye drop. Patient factors that increase systemic absorption include lax eyelids and hyperemic or diseased eyes. Absorption is more of a problem in infants and in the elderly than other individuals. The formulation affects absorption by determining the amount of time the medication stays in contact with the conjunctiva. Ointments are more completely absorbed than suspensions, and suspensions are more completely absorbed than solutions. and this is related to absorption. Minimize systemic absorption of ophthalmic drops by compressing the lacrimal sac for 3 to 5 minutes after installation. This slows down or retards the passage of drops to other areas of absorption. Eye drops must be used properly to be effective. 1 drop of medication is all the eye can retain. Using 2 drops is wasteful. If more than 1 drop is used, the patient should wait 5 minutes before applying a second drop. Patients should not use eye cups because of the risk of contamination, and then they could develop a secondary infection. For bacterial conjunctivitis, topical ocular anti-infectives are used to treat the external bacteria infections of the eyelid and its adnexa, such as conjunctivitis, corneal ulcers, dacros, chirocystitis, and hordeolum. The usual course of treatment is 3 to 5 days, but the treatment may extend to 7 days. You usually treat both eyes if the patient has an infectious conjunctivitis, because with rubbing of the eyes or touching of the eyes, it will easily spread to the other eye. Most antibiotics are effective. The least expensive broad-spectrum agent is usually the preferred treatment. Sulcamide sodium, installed 3 or 4 times a day, is usually considered first line of treatment. If the patient is allergic to sulfa, select another medication that is active against gram-positive bacteria, such as erythromycin. Neosporin is limited by the frequency of allergies to neomycin. The use of topical fluoroquinolones has been discouraged due to resistance. Gonococcal and chlamydial conjunctivitis are usually treated with systemic antibiotics. Prolonged use of topical antibiotics may result in overgrowth of non-susceptible organisms, including fungi. Ophthalmic ointments may retard corneal wound healing as well. For the viral conjunctivitis, it's usually not treated with an antiviral. However, some infections caused by organisms such as herpes simplex are treated with antiviral ophthalmic products. Ganciclovir should be prescribed only for patients who have been given the clinical diagnosis of hepatic keratitis by an ophthalmologist. Systemic absorption is negligible, and some practitioners routinely treat viral conjunctivitis caused by an adenovirus with topical anti-infectives only to prevent secondary bacterial infections. However, this practice is controversial. You don't want to build up those resistance. Some school systems require the child with pink eye be treated before returning to school. Artificial tears, topical antihistamines, and cold compresses might help with symptomatic treatment. If the conjunctivitis is severe or fails to resolve within 3 weeks, the patient should be referred to an ophthalmologist. Allergic conjunctivitis is very common as well, and any allergic rhinitis should be treated appropriately first unless an ocular symptom is severe. Systemic antihistamines can be somewhat useful. Intranasal corticosteroid sprays are also effective. If ocular symptoms persist after allergies are adequately controlled, consider local treatment. First-line treatment is a topical histamine, receptor antagonist, or non-steroidal anti-inflammatory agents. Topical mast cell stabilizers have a slower onset of action but are good for long-term treatment. Optical non-steroidal anti-inflammatory drugs are less effective than antihistamines, and topical ophthalmic decongestions are not drugs of choice because of the short duration of action and adverse effects. These would include blurring, stinging, and rebound hyperemia. Systemic antihistamines may be useful. Severe allergic conjunctivitis may require topical corticosteroids, and this is usually left as last resort. Providers should not prescribe steroid eye drops. They should be ordered only by an ophthalmologist after they have been examined with a slit lamp. Corticosteroids suppress the body's inflammatory response. They delay healing and may allow bacteria to overwhelm the area and produce serious infections. Steroid eye drops may increase the virulence of a herpes infection and potentiate both fungal and bacterial infections. Long-term use of steroids may lead to glaucoma or cataracts. So, again, many different treatment options. How to monitor. You need to monitor the effect for the local and systemic adverse reactions. For antibiotics, long-term use of topical products requires periodic exams for such signs as itching, redness, edema, the conjunctiva, and eyelid, or failure to heal. These could be signs of sensitization. In severe cases of infection, examination of stained conjunctival scrapings and culture studies are also recommended to identify the bacteria. For non-steroidal anti-inflammatory agents, Acular solution or Voltaren solution are often used. They relieve the ocular itching caused by seasonal allergic conjunctivitis. This drug has no effect on intraocular pressure and does not appear to potentiate the spread of infection. The mechanism of action is thought to be due to its ability to inhibit prostaglandins biosynthesis. Ocular administration reduces prostaglandin F2 levels in the aqueous humor. Mast cell stabilizers such as allocril, pantanol. These mast cell stabilizers inhibit type 1 immediate hypersensitivity reactions. Therefore, they inhibit the increased cutaneous vascular permeability that is associated with immunoglobulin E and antigen-mediated reactions. This prevents antigen-stimulated release of histamine and other mast cell inflammatory mediators and inhibits the eosinophil chemotaxis. And if you can remember from pathophysiology, you see an increase in these eosinophils with allergic reactions. The exact mechanism of action is unknown of these mast cell stabilizers, but the drug has been reported to prevent calcium influx into the mast cell upon antigen stimulation. The drug has no intrinsic vasoconstrictor or anti-inflammatory activity. Olopatadine is the first ophthalmic agent with both antihistamine as well as mast cell stabilizing effects. For the glaucoma medication, studies have found, there's one British study in 2011 that found 25% lower risk of low ocular perfusion pressure among men and women who perform moderate physical exercise during a 15-year period. The study did fail to explain the link between ocular perfusion pressure and cardiovascular fitness. However, there has been an association between sedentary lifestyles and factors that increase glaucoma risk. For other ophthalmic medications, the sympthomimetics, such as phenylephrine, hydrochloride, or neosynephrine, a 0.12% solution is available over the counter for relief of minor eye irritation. Ophthalmologists use 10 and 12% solutions for vasoconstriction and pupil dilation. These higher percentage solutions can cause significant cardiovascular adverse reactions, so they need to be used cautiously in patients with cardiovascular disease. In the eye, the phenylephrine acts locally as a potent vasoconstrictor and mydriatic by constricting ophthalmic blood vessels and the radial muscle of the iris. Little rebound vasodilation occurs, and systemic side effects are often uncommon. Ophthalmic solutions composed of phenylephrine hydrochloride are contraindicated in persons with narrow-angle glaucoma, and again cautious with a higher percentage with patients with cardiovascular disease. There's also immune modulators such as cyclosporin or Restasis. This is used for treatment for xerophthalmia by increasing tear production in patients whose tear production is presumed to be suppressed due to ocular inflammation associated with keratoconjunctivitis. The use of this medication is to install 1 drop to the affected eye twice daily, 12 hours apart. For the lubricants, artificial tears naturel, these could be used as often as a patient wishes. Insert systems are indicated in patients with moderate to severe dry eye syndromes, especially in those who a trial of therapy with artificial tear solutions have been unsuccessful. It's also indicated for patients with exposures to keratitis, decreased corneal sensitivity, and recurrent corneal erosions. For anesthetics, again, these are usually not used by the patient at home. It's for the onset of anesthesia after installation of 1 drop. This usually occurs within 20 seconds and lasts for 15 to 20 minutes. So for patient variables, for geriatric patients, older patients are susceptible to systemic effects of the topical eye drops, and results may be unpredictable. For example, beta blocker eye drops are used for glaucoma. These can exacerbate chronic heart failure or even make it better. Hallucinations have also been noted to occur. These should be used with caution and monitored closely for adverse reactions in the geriatric population. However, no dosages need to be changed for the ophthalmic use in the elderly. And these medications can be used in pediatrics, pregnancy, and lactation. Erythromycin has been used frequently in newborns as well as pregnant women. If the patient experiences any reaction, he or she should discontinue the medication immediately and call a provider. Some products may be absorbed by soft contact lenses, so the patient should avoid wearing soft lenses or any contact lenses when using these medications. Store medication or over-the-counter is patient should follow the directions on the package. For eye drops, to install these medications, the patient should wash their hands, tilt the head backward or lie down and gaze upward. Grasp the lower eyelid below the eyelashes and pull the eyelid away from the eye to form a pouch-like. They are to place a dropper directly over the eye, but avoid contact of the dropper with the eye, or avoid contact with the finger or any surface. The patient should look upward just before applying the drop, and after installing the drop, they should look downward for several seconds. They can then release the lid slowly and close the eye gently. With the eyes closed, they should apply gentle pressure with fingers to the inside corner of the eye for 3 to 5 minutes. This will help to avoid a systemic absorption. The patient should not rub the eyes or squeeze the eyelid and minimize blinking. For the ointments, again, the patient should wash the hands, hold the ointment in the hand for a few minutes to warm the ointment and facilitate the flow of the ointment. The patient should tilt their head backward or lie down and gaze upward, gently pull down on the lower lid to form the pouch again, and place 0.25 to 0.5 of an inch quarter to a half of an inch of ointment with a sweeping-like motion inside the lower eyelid by squeezing the tube gently and slowly releasing the eyelid. The patient should close the eye for 1 to 2 minutes and roll the eyeball in all directions. Temporary blurring of vision may occur. Use at night and remove excessive ointment around the eyes with a tissue. For antibiotic installation, again, bacterial conjunctivitis is contagious. It's usually transmitted through direct contact via fingers, towels, handkerchiefs, anything that's moved to the other eye or to other individuals. Warm compresses may be applied to the affected eyes, and this can to aid in the removal of crusting. The patient should not exceed recommended dose or length of treatment. This may cause a secondary infection to occur. Infection can be spread if more than one person uses the medication from the same container, so please instruct the patient to only use their medication. Do not let other members use the medication as well. So we'll move on to topical ear agents and external ear conditions. These medications are used for superficial infection of the external auditory canal and for cerumen removal or earwax. A large number of otic preparations are available. Some are given by prescription only, others are available over the counter. Commonly used prescription topical otic preparations include an antibiotic and an antibiotic plus a hydrocortisone liquid. Miscellaneous otic preparations contain a variety of combinations of ingredients, but we'll talk about the most commonly used products. Steroids, these have an anti-allergic, antipyretic, and anti-inflammatory effects. Antibiotics, as we all know, have the antibacterial activity. Phenylephrine is a vasoconstrictor and has a decongestant effect. Acetic acid, boric acid, benzalkonium chloride, and aluminum acetate or boro solution have antibacterial as well as antifungal activity. Carbamide peroxide emulsifies and disperses earwax. Glycerin is a solvent and vehicle. It has emollient, hygroscopic, and hemorrhagic effects. Benzocaine is a local anesthetic, and antipyrine is an analgesic. Hydrocortisone 1%, neomycin sulfate 5 milligrams, polymyxin 10,000 units, which is the corticosteroid otic solution, ciprofloxacin 2 milligrams per ml, and hydrocortisone 10 milligrams per ml. Cipro HC otic suspension are examples of antibiotic otic agents. These are used for perforated tympanic membranes. These are contraindicated in perforated tympanic membranes. However, they're used often for patients with ear infections. So you need to do a thorough ear exam and make sure that that tympanic membrane is not perforated, so that these medications are not used. They're also contraindicated in any patients who have hypersensitivity to any component of the agent. Precautions, prolonged use of antibiotics or steroids may result in overgrowth of non-susceptible organisms. For herpes simplex, varicella, and fungus. Adverse reactions can occur, including rash, itching, and swelling. These are signs of hypersensitivity to any component of the product. And drainage and pain may signify a middle ear infection, and drops are then contraindicated. Drainage may also indicate perforated tympanic membrane, and again, these should not be used with patients with perforated tympanic membranes. For dosage and administration, the usual adult dose is 4 drops 3 or 4 times a day. The usual dosage for infants and small children are 3 drops to the affected ear 3 or 4 times a day. A wick may be inserted into the canal after the drops have been placed, and more drops may be applied to saturate this wick. If this is the case, instruct the patient to put a few drops on the wick every 4 hours and remove the wick after 24 hours. However, once they remove the wick, they should continue to place drops 3 or 4 times a day in the affected ear. Treatment principles, evidence-based recommendations. One study has shown no difference in efficacy between wax softening agents and saline sterile water solutions. There is limited good quality evidence, but softeners appear to be more effective than no treatment at all. Evidence for irrigation or mechanical removal of earwax is equivocal. So for cardinal points of treatment, these ear agents act topically and exhibit minimal systemic absorption. When an ear infection is treated, the other ear also may be treated as a preventative measure. A steroid is usually indicated with an antibiotic to relieve the symptoms of the infection. The patient should only use drops for 1 week only. To prevent infection in patients at risk, such as swimmers, they can use a product that contains 2% acetic acid, boric acid, isopropyl alcohol, or boro solution after exposure. These are available over the counter and can be made at home. To prevent wax buildup, glycerin or an oil such as mineral oil or vegetable oil regularly, weekly or monthly, helps to prevent the buildup. An over-the-counter preparation that contains triethylamine may also be used. To treat impacted wax or cerumen, the patient should use over-the-counter eardrops nightly for 4 to 7 days. They should avoid ear candles because patients may get burned. Excessive wax may be removed as a procedure in the office if necessary. How to monitor these patients? Patients need to be monitored for therapeutic effect as well as hypersensitivity reactions. The patient should use only in the ears and avoid any contact with the eyes. They should notify their provider if burning or itching occurs or the condition persists. They should only use for prescribed length of treatment. As I said earlier, no longer than 1 week's time. They should use the eardrops properly, wash hands well before installing the drops. Avoid contact of the sterile tip with any part of the ear. For improved accuracy, another individual could place the drops in the ear canal if possible. The patient should warm the bottle to body temperature by holding it in the hand for 10 minutes prior to using. They should shake suspensions for 10 seconds to mix well. Patients should lie on their side or on their back with the affected ear up. For a child, you should pull the ear down and back due to their different anatomy. For an adult, you should pull the ear up and back. You should instill the prescribed number of drops into the ear and keep the ear tilted for 2 minutes or insert a cotton plug. Again, treat for the recommended length of time, but not longer than a week. So let's move on to topical mouth and throat agents. We'll just quickly talk about this. The most common antifungals are nystatin, and these are for treatment of oral candidiasis or yeast infections, prophylaxis in immunocompromised patients. herpes, or cold sores, minor sore throats, or minor irritations of the mouth or throat. They are usually associated with antibiotic treatment and immunocompressed patients. The antiviral product penciclovir is used for herpes or cold sores. Carbamide peroxide is indicated for the relief of minor oral inflammation such as canker sores, denture irritation, and irritation of inflamed gums. Pilocarpine, taken as a 5 milligram tablet, is indicated for dry mouth and salivary gland hypofunction caused by radiotherapy or Sjogren's syndrome. Because of the risk of serious parasympathetic adverse effects, its use should be reserved only for patients with a clear indication and significant consequences from dry mouth. A wide variety of mouth and throat products with various combinations of ingredients are used for minor irritations of the throat and mouth. Many are safe and effective, and many are available over the counter. The most frequently used ingredients, again, include the carbamide peroxide, urea peroxide. It's used for treatment of minor oral inflammation because it releases oxygen on contact with the mouth tissue to provide a cleansing. Chlorhexidine gluconate is used for gingivitis because it provides microbicidal activity during oral rinsing. Antipyrine is an analgesic. Benzocaine and cyclopamide are local anesthetics. Hydrocortisone and trimethylene corticosteroids have anti-inflammatory activity. Oils, thymol, have antiseptic activity. Menthol, camphor, and phenol have antipyretic, local anesthetic, and counter-irritant activity. Saliva substitutes are used to relieve dry mouth or throat. Again, only for those with severe conditions. Tannic acid is used for temporary relief of pain caused by cold sores because it forms a thin, pliable film over the sores within 60 seconds of administration and helps prevent irritation. Terpene hydrate is an expectorant, and this is also sometimes used. For patient education, to use the suspension form of the drug, it should be used as directed. The patient should divide the dose and place half on one side of the mouth and other half on the other side. They should retain the suspension in the mouth for as long as possible before swallowing and continue use for at least 2 days after the symptoms disappear. To use the Troche form, the patient must be competent enough to allow it to dissolve slowly. It should not be chewed or swallowed whole, and it should be dissolved slowly in the mouth. So now we're going to talk about common upper respiratory agents. The most common conditions in primary care that require these medications are upper respiratory viral infections, or URIs, or viral rhinitis, and allergic rhinitis, or hay fever. Bacterial infections, we've already covered in use of antibiotics, so we'll just talk about the viral infections now, or allergic infections. Decongestants and antihistamines are commonly used both over-the-counter and by prescription for treatment of a variety of conditions. Decongestants are used as first-line drugs for upper respiratory infections. Antihistamines are first-line treatment for allergic rhinitis. Leukotriene receptor antagonists may be used as first-line treatment for allergic rhinitis, but are typically prescribed when other treatments fail to relieve symptoms. Intranasal steroids and cromolyn are generally considered second-line treatment for upper respiratory conditions, Oral formulations of these drugs are used for lower respiratory conditions. Antitussives and expectorants are used as adjunct therapy in upper respiratory and lower respiratory conditions. Combination drugs that contain these different categories of medication are available both over-the-counter and by prescription. These combination product ingredients change rapidly, and this may be very confusing to the patient. Often the over-the-counter combinations purchased by the patients contain medications that are not indicated for the condition for which the combination is labeled, and can be counterproductive in clearing up their symptoms. Many of the nighttime formulations contain alcohol and acetaminophen, which should not be used together. Some products over the counter taken incorrectly, taken an antihistamine for congestion when actually a decongestion is needed, often occurs. Products with analgesics are often used by patients even when the patients do not have pain or fever. Many patients, particularly the elderly, use these products without considering the ingredients and possible drug interactions with the medications that they're already taking, or pre-existing medical conditions that may adversely be affected by certain medications. An example of this would be patients with hypertension, glaucoma, or urinary tension who take pseudoephedrine for congestion. These patients take over-the-counter medications for respiratory problems. So you need to really ask the patient specifically about the use of over-the-counter products. Despite these problems, commonly prescribed combination medications are important in the treatment of respiratory problems and include antihistamine and decongestant combinations such as Allegra D, Claritin D, and Zyrtec D, decongestants with expectorant combinations such as Gudafed PD, and antitussive expectorant combinations such as Robitussin AC or Robitussin DM. These can be useful in the treatment of multi-symptoms related to the upper and lower respiratory conditions, and can be helpful if used appropriately. As a clinician, you should suggest special formulations that are available over the counter for patients with hypertension, such as Coricidin HBP or Coricidin HBP cough and cold. These are appropriate for those patients, and several products are sugar and alcohol free. Despite the multiple combination preparations, they are available both over the counter and by prescription. Many recommend prescribing single agent medications to avoid any drug errors or over-medication. So again, let's look at the indications for decongestants. Oral decongestants are used for nasal congestion caused by the common cold, hay fever, or other respiratory allergies. Nasal congestion associated with sinusitis, and ear tube congestion, and they're also unlabeled use for treatment of mild to moderate urinary stress incontinence. Topical nasal decongestants are used for symptomatic relief of nasal and nasopharyngeal mucosal congestion caused by the common cold, sinusitis, hay fever, or other upper respiratory allergies. Adjunctive therapy for middle ear infections by decreasing the congestion around the ear canals, and relief of ear block and pressure pain in ear travel. Antihistamines are used for symptomatic relief of symptoms associated with seasonal allergic rhinitis, vasomotor rhinitis, and allergic conjunctivitis. They're used for temporary relief of runny nose and sneezing caused by the common cold. For antihistamines of the skin, these are used. Antihistamines are also used for the skin for allergic or non-allergic pruritic symptoms, mild, uncomplicated urticaria and angioedema. Reactions to blood or plasma and anaphylactic reactions are often treated with antihistamines as well. For the intranasal corticosteroids, vasomotor rhinitis and relief of symptoms of seasonal or perineal rhinitis when effectiveness of the antihistamines or tolerance to treatment develops. The intranasal mast cell stabilizers are used for prevention and treatment of allergic rhinitis. Antipassives can be both narcotic as well as non-narcotic. The narcotic ones are codeine for suppression of cough induced by chemical and mechanical respiratory tract infections, and the non-narcotic antitussives such as Robitussin for suppression of non-productive coughs, as well as Tessalin pearls for the symptomatic relief of coughs. Finally, expectorants, guaifenesin, may provide some symptomatic relief of respiratory conditions characterized by productive or non-productive cough. However, you need to find out the cause of these coughs to make sure that you're treating appropriately. Decongestions are sympathomimetic amines that act to stimulate alpha adrenergic receptors of vascular smooth muscles and cause vasoconstriction. This results in nasal decongestion, contraction of gastrointestinal and urinary sphincters, pupil dilatation, and decreased pancreatic beta cell secretion. Pseudoephedrine also has beta adrenergic properties that cause relaxation of the bronchi. Nasal sprays or inhaled topical application of decongestants to the nasal mucous membranes cause vasoconstriction, resulting in shrinkage, which helps to promote drainage and improve breathing through the nasal passages. These inhaled agents produce reduced systemic effects compared with the oral preparations, achieving decongestion without causing sudden or wide changes in blood pressure, cardiac stimulation, or vascular redistribution. Oxymetazoline is a topical, direct-acting sympathomimetic amine that acts on the alpha-adrenergic receptors of the nasal mucosa, causing vasoconstriction and resulting in decreased blood flow and decreased nasal congestion. In sympathetic nervous system, adrenergic effector cells contain two distinct receptors, the alpha and beta receptors. Sympathomimetic drugs mimic the action of norepinephrine or sympathetic effector organs, thereby affecting the adrenergic receptors. Important alpha adrenergic activities include vasoconstriction of the arterioles, leading to increased blood pressure, dilatation of the pupils, intestinal relaxation, and bladder sphincter contraction. Beta receptors are divided into the beta 1 and beta 2 receptors because some drugs affect some but not all beta receptors. Beta 1 adrenergic activity includes cardio acceleration and increased myocardial contractility, whereas beta 2 stimulation leads to vasodilatation of skeletal muscle, bronchodilation, uterine relaxation, and bladder relaxation. We've talked about the beta blockers in cardiac, and now we look at these for decongestants and bronchodilation. So the beta adrenergics, the beta 1, again, activity includes cardiac increase in cardiac acceleration and myocardial contractility. The beta 2 cause vasodilatation of skeletal muscles, bronchodilation, uterine relaxation, and bladder relaxation. The alpha adrenergic causes vasoconstriction of the arterioles, which increases blood flow and blood pressure, dilatation of the pupils, intestinal relaxation, and bladder sphincter contraction. So what is the mechanism of action of the decongestion? The pseudoephedrine is an alpha-adrenergic receptor antagonist. It's a symptomimetic that produces vasoconstriction by stimulating alpha receptors in the mucosa of the respiratory tract. It reduces tissue edema and nasal congestion, increases nasal airway patency, promotes drainage of sinus secretions, and opens obstructed tubes in the ear. Pseudoephedrine is also used in the illegal manufacturing of methamphetamine. State and federal regulations now restrict the sale of pseudoephedrine, and it's now stored behind the pharmacy counter. In some states, it's only available by prescription, and many manufacturers are using formulations that contain phenylephrine in non-prescription preparations. Again, phenylephrine acts directly on alpha-adrenergic receptors and can be administered orally or topically to relieve nasal congestion in upper respiratory infections, sinusitis, and allergic rhinitis. The efficacy of oral phenylephrine has not been studied extensively. Antihistamines compete for histamine at the H1 receptor sites and are used to treat immunoglobulin IgE-mediated allergies. Antihistamine therapy is helpful in treating allergic rhinitis and urticaria in most but not all patients. Antihistamines antagonize the pharmacological effects of histamine. They do not inactivate histamine or block histamine release, antibody production, or antigen-antibody interactions. They also have anticholinergic or drying effects, antipyretic, and sedative effects to varying degrees. These drugs are classified by the amount of sedation they cause. Azathiolene is a topical antihistamine nasal spray with few adverse systemic effects that is used to treat allergic and vasomotor rhinitis. For the intranasal corticosteroids, the steroids are used in intranasal products, have potent glucocorticoid and weak mineral corticoid activity. Glucocorticoids inhibit cells, including mast cells, eosinophils, neutrophils, and macrophages, as well as lymphocytes and mediators such as histamine, leukotrienes, and cytokines. They exert direct local anti-inflammatory effects with minimal systemic effects. Intranasal corticosteroids effectively control the 4 major symptoms of allergic rhinitis, which includes the rhinorrhea, congestion, sneezing, and nasal itch. They are helpful in managing moderate to severe disease and are used in treating both seasonal and perennial allergic rhinitis. These medications must be used consistently on a daily basis for effectiveness, and maximum effect may not be noted for several days. For the intranasal mast cell stabilizers, such as cromolyn sodium, this is an over-the-counter intranasal mast cell stabilizer that is used as a preventative agent that is taken in advance of exposure to allergens. It's an anti-inflammatory agent that has no intrinsic bronchodilator, antihistamine, vasoconstrictor, or glucocorticoid activity. The chromalin inhibits sensitized and mast cell degranulation that occurs after exposure to specific antigens. The drug inhibits the release of mediators, histamine, and slow-reacting substance of anaphylaxis from the mast cell. It inhibits calcium from entering the mast cell, resulting in the prevention of mediator release. It is effective in reducing rhinorrhea, sneezing, and nasal itch, but has minimal effects on nasal congestion. Chromalin acts locally on tissue, inhibiting the release of chemical mediators by preventing mast cell degranulation. It has an excellent safety profile and minimal adverse effects consisting of nasal irritation, stinging, and sneezing. Chromalin must be taken properly as a nebulized aerosol, inhaled through the mouth, or swallowed orally 4 to 6 times a day, and its effect may also not be seen for 4 to 6 weeks or even months after beginning use. For the leukotriene receptor antagonist, monoleucate sodium, a leukotriene receptor antagonist causes inhibition of airway cysteinol leukotriene receptors, the CystTLs, which are products of arachidonic acid metabolism that are released from mast cells and eosinophils. Again, the eosinophils are what we see in allergic reactions. These CystTL type 1 receptors are found in airway smooth muscle cells, airway macrophages, and pro-inflammatory cells such as the eosinophils and myeloid stem cells. The CYSTLs are released from the nasal mucosa after allergen exposure occurs and are associated with symptoms of allergic rhinitis. For the antipassives, codeine and dextromorphan both act centrally by acting on the cough center of the medulla to suppress coughs. Dextromethorphan is the D-isomer of codeine that lacks the analgesic and addictive properties of codeine. However, it is not as effective as codeine in depressing the cough reflex. Benzonate, which is tessalin pearls, acts as an acts to anesthetize stretch receptors in the respiratory passages, reducing the cough reflex at its source. The expectorants, you have guaifenesin, which increases the respiratory tract fluid secretion and helps to loosen bronchial secretions by reducing adhesiveness and tissue surface tension. By reducing the viscosity of secretions, guaifenesin increases the efficacy of the mucociliary mechanism in removing accumulated secretions from the upper and lower airways. As a result, non-productive coughs become more productive, less frequent, and less irritating to the airways. Guaifenesin products that are marketed as sustained or time-released have come under FDA scrutiny. Time-released over-the-counter drugs require FDA approval because the FDA must ensure that the product releases its active ingredients safely and effectively, sustaining the intended effect over the entire time for which the product is intended to work. Many sustained release products have been on the market without receiving this approval. Guaifenesin is classed as questionably effective in some studies. So for the treatment principles, non-pharmacological treatment for the URI consists of rest, increased fluids, especially water, adequate hydration may be more helpful in symptom relief than medication because it helps to decrease the cough, thin secretions, and hydrate the tissues. Use a teaspoon of honey The use of a teaspoon of honey has been shown to be effective in reducing coughs in small children, and for non-pharmacological treatment of allergic rhinitis, identifying environmental precipitants, which may include the time of the year, work and home environment, as well as pets. Implement strategies designed to reduce these factors. Avoid outdoor allergens. Use air conditioning in home and car. Exercise outdoors in the afternoon when the pollen counts are typically lower. Use high efficiency air filters in the home, and use a dryer rather than a clothesline when clothes can need to be dried, where clothes can collect these airborne pollens. For indoor allergens, use strategies for dust, pet, mold, and cockroach avoidance. Normal saline nasal sprays or nasal irrigation twice daily may help reduce postnasal drip, sneezing, and congestion. Ask the patients if they're using complementary or alternative medications, many of which interact with drugs given for these upper respiratory problems. For pharmacologic treatment, patient's history reveals which symptoms are most troublesome and can be targeted. Decongestants, antihistamines, or combination proven effective. Antitussives or expectorants may be helpful. Because upper respiratory infections are mostly viral in origin, antibiotics usually are not indicated. Many patients must have this important fact explained to them because they expect to walk out of the office with a prescription. Pharmacological treatment of allergic rhinitis involves identifying and targeting the symptoms that are most problematic of the patient. These often include sneezing, runny nose, itching, and nasal congestion. Treat mild, intermittent symptoms with an antihistamine, preferably non-sedating, or a decongestant. If the patient is unable to take an oral antihistamine, consider the use of nasal antihistamines, intranasal cromolyn, or leukotriene receptor antagonists. Treat moderate, frequent symptoms with regular to high dose intranasal corticosteroids. Add an oral or nasal antihistamine and decongestant if necessary. Treat moderate persistent symptoms with combination regimen consisting of intranasal corticosteroids plus a non-sedating or intranasal antihistamine and decongestant if necessary. Treat severe symptoms with a combination regimen consisting of non-sedating antihistamines or with or without a decongestant and intranasal corticosteroids. Consider the use of an oral steroid for 5 days, as well as the use of oxymetazoline as needed for no longer than 3 days. The common drugs which are widely available without prescription are very effective in treating nasal congestion. Decongestions are symptomimetic amines used to relieve nasal congestion caused by colds, allergies, and URIs. They also promote sinus drainage and relieve ear tube congestion. Oral forms are often used in combination with antihistamines and expectorants in both over-the-counter and prescription doses. Topical nasal decongestants provide direct relief to swollen nasal membranes and sometimes are used to decrease congestion of the eustachian tubes in the middle ear infection and to relieve pressure and blockage of the ear during air travel. Decongestions should be used with caution in patients with hypertension, cardiovascular and peripheral vascular disease, hyperthyroidism, diabetes mellitus, prosthetic hypertrophy, urinary retention, and increased intraocular pressure because of the symptomimetic effects. They are contraindicated in patients with mitral valve prolapse and cardiac palpitations. They also have many side effects that can limit their use, particularly in the elderly. Oral decongestants generally do not cause sedation but may cause systemic effects. including nervousness, dizziness, difficulty sleeping, particularly in infants and elderly. The clinical problems most often seen with oral decongestions include tachycardia, nervousness, insomnia, palpitations, headache, and irritability, which may be poorly tolerated in the frail elderly. Patients with poorly controlled hypertension may experience an increase in blood pressure. The provider should question the patient thoroughly about his or her history of decongestant use. Patients may voice complaints of their heart racing or that the drugs keep them awake at night. Data suggests that oral decongestions may be used cautiously in patients with controlled hypertension. Sustained release formulations may have less of an effect on the cardiovascular system. However, because they may antagonize the effect of antihypertensive medications, alternative agents such as topical decongestion should be used for these patients. The FDA, again, has determined that the combination of pseudoephedrine and caffeine is not recognized as safe and effective for over-the-counter use. Cough and cold formulations for children under the age of 6 are not recommended, and most manufacturers have removed these products from the market because of so many cases of accidental overdosages. Topical decongestions have little systemic effects, but because of rebound congestion, they should be used only in acute conditions for no longer than 3 consecutive days. Rebound congestion is treated by gradual withdrawal, 1 night at a time, of the medication. Saline nasal spray is often helpful. Overall, topical decongestions are more effective than oral ones, but oral decongestions have longer durations of action and are less irritating. For the pharmacological treatment with antihistamines, antihistamines are H1 receptor antagonists that are often used alone or in combination with decongestants and expectorants to relieve those symptoms associated with allergies, as well as associated with rhinitis, vasomotor rhinitis, allergic conjunctivitis, and cold symptoms such as sneezing and runny nose. They are also used to relieve allergic and non-allergic pruritic symptoms, to elevate mild urticaria and angioedema, for prophylaxis against allergic reactions to blood or plasma products, and adjunctive therapy and anaphylactic reactions. Certain antihistamines also have an antiemetic effect and are useful for nausea, vomiting, vertigo, and motion sickness. Many of the over-the-counter cold remedies contain antihistamines. However, their use in the treatment of cold symptoms is controversial. Antihistamines are best used to treat allergic symptoms such as rhinorrhea, watery, itchy eyes, postnasal drainage, and sneezing. Decongestants are preferred for the treatment of cold symptoms such as nasal congestion caused by swollen nasal membranes. In general, the antihistamines are not recommended to treat lower respiratory tract infections or symptoms, including asthma, because of their anticholinergic effects, may cause thickening of respiratory secretions, and may impair expectoration. Several evidence-based reports, however, indicate that the antihistamines can be safely used in asthmatic patients with severe allergies without exacerbating their asthma. 2 generations of antihistamines are available. The first generation agents are usually available over the counter and often are used before a healthcare provider is consulted. Most cause sedation and have sometimes been included in sleep aids. However, they remain highly effective in symptomatic treatment, and some products have been released by prescription only that provide new delivery systems that decrease drowsiness. Second-generation antihistamines are favored in practice for their efficacy and safety ratio and rapid onset of relief from sneezing, pruritus, and watery rhinorrhea. Most are now available over the counter. All antihistamines are not very effective against nasal congestion and may even compound or contribute to its development. Local antihistamine nasal sprays and various ocular antihistamines are also effective in less than 30 minutes. Over-the-counter antihistamines that generally cause sedation may interfere with the patient's activities and contribute to to poor adherence. Therefore, an antihistamine and decongestant often are combined to counteract the side effects of each drug while providing dual treatment. Sedating antihistamines are sometimes preferred if symptoms prevent the patient from sleeping, and sedating antihistamines are often used in combination with analgesics as a pain reliever and sleep aid. Prescribed antihistamines are less likely to cause sedation and are generally well tolerated. If a particular antihistamine has lost its effectiveness or causes untoward side effects, another antihistamine should be selected from a different class. If the patient requires 2 antihistamines for severe symptoms, drugs from 2 different classes should be selected. Citrazine was recently put on the FDA drug watch list because of its incidence of ocular uric crisis. Intranasal corticosteroids are the most effective agents for the management of allergic rhinitis because of their direct reduction of nasal inflammation and their ability to reduce nasal hyperactivity. All agents are safe and effective and will improve the patient's quality of life if the patient uses them on a daily basis. Many patients do not like the odor or taste associated with specific agents, and 1 or 2 different medications may have been tried before the most tolerable agent can be found for an individual. It is essential for the provider to help the patient understand the important role of these agents and to demonstrate how they should be administered correctly. Intranasal corticosteroids should be used at least 1 month before it's decided whether they are effective. Patients should be warned that improvement usually does not begin until 1 to 2 weeks after therapy is started, and intranasal corticosteroids can be used with asthmatic patients and with those who have comorbid nasal polyps. Intranasal steroids may help to shrink these nasal polyps. Exceeding the recommended dose may result in systemic effects, including suppression of the hypothalamic pituitary adrenal axis function. Systemic effects are possible with inhaled steroids and are less likely with intranasal corticosteroids when used at conventional recommended dosages. It should be noted that in some cases, oral corticosteroids may be required for a short period of time. However, these powerful drugs reduce nasal inflammation and hyperreactivity, but they also have the potential serious side effects when used over a prolonged period of time. A short course of tapered corticosteroids is advisable only for moderate to severe exacerbations of allergic rhinitis. The mast cell stabilizers, these agents are particularly effective in patients with intermittent allergies, especially when these are determined to be prevalent during only 1 season of the year. They usually are available over the counter and should be started 3 to 4 weeks before the peak allergy season occurs. Their effect on the nose is short-acting and that makes compliance more difficult because several doses are needed during the day. Intraocular agents are also very effective. The patient should continue treatment throughout exposure. For allergic rhinitis, effects of the treatment may not appear for 2 to 4 weeks after treatment is first initiated. The need for medication may diminish and it can be discontinued later. For the leukotriene receptor antagonist, monoleucase sodium, which is a leukotriene receptor antagonist, is used for the relief of symptoms of allergic rhinitis in adults, particularly those with asthma, and pediatric patients 2 years of age and older, as well as the treatment for seasonal allergic rhinitis in adults and pediatric patients 6 months or older. Leukotrienes are associated with early phase allergic symptoms such as sneezing, rhinorrhea, nasal itching, as well as late phase reactions such as congestion, sneezing, and rhinorrhea. Anti-leukotriene is used often in combination with other therapies, especially when nasal congestion is not resolved by other modalities. The antitussives are used to control or suppress cough caused by respiratory tract irritation, colds, or allergies. It's important to determine the underlying cause of the cough, particularly to rule out any serious causes of the cough. Antitussives should not be given in conditions in which retention of respiratory secretions may be harmful. Antitussives should be used with caution. In general, cough should not be suppressed. Coughing helps to bring up fluid from the bronchioles and lungs. However, if patients are having a non-productive cough that is causing muscle pain or interfering with sleep, it should be suppressed. Antitussive preparations are available in liquid and tablet forms. Patients often expect or prefer a cough syrup for cough suppression. Prescribing cough syrups may provide some psychological benefit. A simple cough syrup that contains guaifenesin but no other drugs, including alcohol, causes no harm, soothes the throat, and makes the patient feel cared for. A cough syrup without sugar is made for diabetic patients. These can be used in the patient for whom any other medications are unsafe. Most effective in suppressing coughs are the narcotic antitussives. Codeine as a narcotic antitussive is used to suppress cough induced by chemical or mechanical respiratory tract infections. It's also used as a narcotic agonist analgesic for the relief of mild to moderate pain. The antitussive dose of codeine is lower than that of the required dose for analgesia, and side effects are less frequent at the antitussive dose. Cough suppression with codeine is therefore beneficial at bedtime in patients who have cough-related pain or complications such as costochondritis or sleeplessness caused by deep or persistent coughs. Hydrocodone, also a narcotic antitussive and analgesic, has multiple actions similar to those of codeine. Like codeine, it's believed to act directly on the cough center of the brain. Nausea, vomiting, sedation, dizziness, and constipation are the most common side effects of narcotic antitussives. Allergic reactions to opiates are infrequent and usually are manifested by pruritus and urticaria. Narcotic antitussives should be prescribed in small amounts, and patients should be followed closely to determine the effectiveness and to prevent excessive use. These drugs can provide good suppression at doses low enough to provoke few side effects. Non-narcotic antitussives lack analgesic properties and are not as effective as codeine in suppressing coughs, but they also lack the potential for addiction and other adverse effects associated with narcotic use. Dextromorphan is a common ingredient of many over-the-counter cold medications and some prescription cough preparations, so it is frequently used in combination with decongestants, antihistamine, and expectorants. Benzenate in the form of capsules should be swallowed whole, and these can cause temporary local anesthesia of the oral mucosa if not taken correctly. It lacks the CNS side effects of codeine and dextromorphan. However, it is not as effective. Benzenate is often used in patients such as the frail elderly, patients who must continue to perform activities that require maximum mental alertness, such as driving, and for those who are bothered by their cough but cannot tolerate the CNS effects of other cough suppressants. Guaifenesin is an expectorant that is used for the symptomatic relief of dry, non-productive coughs associated with respiratory tract infections. It is also used in related conditions such as sinusitis, pharyngitis, bronchitis, and asthma, and in the presence of mucus plugs, or congestion of the respiratory tract. Guaifenesin is found in many of the over-the-counter preparations as well as prescription preparations. Expectorants are often used in combination with antitussives to provide relief for dry, non-productive cough and to loosen mucus or congestion in the respiratory tract. These agents were once believed to stimulate the flow of mucus. However, no evidence supports this view. Expectorants are often used when the patient insists on a cough remedy when cough suppression is not indicated, or when the patient believes the effect to be beneficial. Enhancing expectoration by thinning thick secretions helps to promote drainage. This can be accomplished through the use of expectorants, by increasing fluid intake, by increasing air humidification. Fluid intake of up to a gallon of water a day for those who do not have fluid restrictions is very important. For patient variables, geriatrics, decongestion, sustained release products should not be used in geriatric patients. Antihistamines are more likely to cause excessive sedation, syncope, dizziness, confusion, and hypertension in elderly patients. A decrease in dosage is usually necessary. This sedation presents a real risk to driving, as well as increasing the risk of falls. Administer the antitussive codeine with caution in elderly and debilitated patients, and in those with severe liver disease or kidney impairment, as well as hypothyroidism, Addison's disease, urethral stricture, and prosthetic hypertrophy. For pediatric patients, avoid sustained release decongestants. For children under 12 years of age, antihistamines may diminish mental alertness. In young children, antihistamines may produce paroxysmal excitation in a syndrome that may include excitement, hallucinations, ataxia, incoordination, muscle twitching, hyperthermia, cyanosis, tremor, and hyperreflexia. This is then followed by respiratory depression and cardiorespiratory arrest. Convulsions in children resulting from antihistamine use may be preceded by mild depression and may indicate a poor prognosis. Dry mouth, fever, fixed dilated pupils, and flushing of the face are common. The convulsant dose of antihistamine is close to the lethal dose. Again, do not give cough or cold products to children under the age of 6. Potential for the overdose and death exists, and these formulations have been removed from the market. These products, if still available in homes, should be discarded. Decongestion products should not be used in nursing mothers. The use of intranasal corticosteroids in prepubescent children poses a potential risk of growth suppression. Studies have shown that used twice a day have shown a significant decrease in growth velocity. This has not been shown in other intranasal steroids other than beclomethasone. And it's possible that growth suppression may be associated with certain agents or may be dose-related. Children who are currently taking oral inhaled corticosteroids for asthma are at increased risk, and when using intranasal steroids in children, use the lowest dosage for a short time and routinely measure growth. Do not use codeine in premature infants. Opiates do cross the immature blood-brain barrier to a great extent, producing significant respiratory depression. Give to infants and small children with extreme caution and monitor the dosage carefully. Caution is recommended in administering expectorants to children up to age 12 years of age with persistent or chronic cough or asthma, or if the cough is accompanied by excessive mucus. A medical evaluation should be conducted before treatment with expectorants. Decongestion products should not be used in nursing mothers. Category B includes antihistamines, such as and some of the leukotriene receptor antagonists. Category C also includes some of the antihistamines, intranasal steroids, antitussives, codeine, and expectorants. Safe use of antihistamines in pregnancy has not been established. Several possible associations with malformations have been found, but the significance is unknown. Use only when clearly needed and when potential benefits outweigh the potential risk to the fetus. Do not use during the 3rd trimester of pregnancy. Newborn and premature infants may have severe reactions. Because of the higher risk of adverse effects in infants in general, particularly for newborns and premature infants, antihistamine therapy is contraindicated for nursing mothers. Patient education, decongestants, pseudoephedrine, such as Sudafed, phenylephrine, Sudafed PE. You should encourage the patient to reduce consumption of caffeine-containing beverages such as coffee, tea, and cola, because this may increase the restlessness and insomnia caused by pseudoephedrine, phenylephrine in sensitive individuals. Use nasal medications for only 2 to 3 days and stop to prevent a rebound in symptoms. Treatment rest cycles may be continued while the patient is symptomatic. Antihistamines such as Benadryl, Tavist, chlorotrimetron, Zyrtec, hydroxine, Allegra, and Claritin. These antihistamines are used to treat allergy symptoms and should not be used to treat URIs, including colds and sinusitis. Do not use alcohol, sleeping pills, sedatives, or tranquilizers while using the antihistamines, and antihistamines may have a sedative effect, causing dizziness in some patients. Patients should avoid driving a car or performing hazardous tasks until the effects of the medication are known. Antihistamines should be stored in tightly closed containers in a cool, dry place away from heat and sunlight, and especially out of reach of children. Some antihistamines may cause stomach upset, and these should be taken with food. Antihistamines may cause photosensitivity. The patient should avoid prolonged sunlight exposure, and they should not crush or chew sustained-release preparations. For the intranasal corticosteroids, such as Nasacort, AQ, use patient information provided with the product on how to use a nebulizer or inhaler. Explain that the patient should not exceed the recommended dosage and clear secretions from nasal passages before using. You can use a decongestant if necessary. The effects are not immediate. Remind the patient that results require regular use and may take up to 7 days. With the intranasal mast cell stabilizers, such as cromolyn, the patient should clear the nasal passages before administering the spray and inhale through the nose during administration. Follow the information provided with the product for correct administration of nebulizer, inhaler, or oral ampules of the medicine, and do not discontinue the therapy abruptly without talking to their provider. For the leukotriene receptor antagonists, such as Singulair, phenylketonuria patients should be aware that 4 milligrams and 5 milligrams tablets contain phenylalanine as an ingredient and should not be taken. Antitussives, codeine phosphate or codeine sulfate, Benylin, Robitussin maximum strength, Tessalin pearls. Patients should contact a healthcare provider if the cough persists for longer than 2 weeks or is accompanied by high fever, rash, or persistent headache. Narcotic antitussives, such as codeine, may impair mental and physical abilities. Patients should be cautioned to avoid performing potentially hazardous tasks, such as driving or operating heavy machinery. Expectorants, gliflozin, such as Robitussin, Mucinex. You need to instruct the patient to drink plenty of water to help loosen the mucus in the lungs, and contact their provider if the cough persists, again, longer for 2 weeks or is accompanied by high fever, rash, shortness of breath, changes in the characteristic of the cough, increasing fatigue, or persistent headache.